Welcome to Innovation in Government, powering the future of health IT, presented by Carahsoft. I'm your host, Francis Rose. Federal health IT leaders say they're entering a new era. The components of that new era include electronic health records, new privacy and security rules, and a growing focus on rural health. Those leaders say they'll incorporate artificial intelligence into the transformation that's coming as health IT rethinks trust, fraud mitigation, and more. That's where I'll start with Tim Boltz of Carahsoft. Tim, welcome. Thanks for joining me. How are electronic health records evolving over time? How are they different now than when the concept first came around?
Yeah, Francis, thanks for having me and for putting on this phenomenal program. The electronic health record is not new. However, it's been monumental in preparing us for the modernization that is happening in IT, health IT today. 20 years ago, or 15 years ago, everything was paper. Everything was, had the limitations of paper. And with the power that AI brings to our healthcare systems and really our treatment plans for patients, EHR is the foundation of that data, right? And so AI is only as powerful as the data that it consumes, right, to power its decisions. And so ensuring that EHR is implemented and really works for the physician and the clinician to spend more time with their patient. And then what I'm really excited about as we really sort of unbox and understand the power of AI is, okay, that data has to be available, it has to be uniform, and it is really what I think is going to be the secret sauce that really promotes and expands a very exciting time to be in health IT, as we're going to see really cool treatments come out that are going to be powered by AI and the EHR.
I keep reading about and hearing about from practitioners across the federal government the fact that EHR are evolving in such a way that, to exactly one of the points that you just made, the caregiver is spending time giving care instead of keeping track of stuff. What's driving that? What are the technology growth? What's the technology growth that's driving that?
Great question. So I think it really hit me. I am a father of two young children, and my daughter, when she plays doctor, she has a laptop. Mm-hmm. And so when I played doctor, 30 years ago, I had a stethoscope and I was treating a patient.
Yeah.
She has a barrier between her and her imaginary patient. Mm-hmm. So that's really when I sort of woke up as a technologist and said, okay, that's wrong.
That's
right?
Not the way it should be.
No. Having technology between a physician or a clinician or someone providing care and their patient, that is not where we want technology to be. We want technology empowering these folks that are doing phenomenal things in cancer research, in vaccine development, in drug development. And so that really set me on my mission of, okay, how do we create technology and solutions with humans sort of, designed, right? Human-centered design. And so I think some wins that we're seeing across the board in health IT, specific to AI, is ambient listening, right? Lots of providers are bringing ambient listening into the patient-doctor conversation. And what that's doing is freeing up the doctor from taking notes to having a conversation like we're having today. Mm-hmm. But yet all of that important information is getting transcribed into the EHR. And if that's getting transcribed into the EHR, okay, the physicians, clinicians are going to have it, right, as they go back and review the patient record. And then as we start to layer in some of these large language models and other things, which are still coming, that is really where I think the rubber meets the road on personalized care, personalized medicine, which is going to transform over the next 10 to 20 years, life expectancy, as well as equity of care. So it's exciting.
There are two things that come to mind as you describe that scenario there. I think about the privacy implications of me saying to an AI bot, essentially, while my doctor is in the room, here's what's going on with me. And then I think about that repository of information of all of those patients in that practice and what the cybersecurity requirements will be. What do privacy and cybersecurity look like in this kind of brave new world that you're describing?
It's all one of the same.
Yeah.
So I think essentially AI is a tool that is going to unlock a lot of doors and really accelerate the way that we deliver care. But with the use of AI comes all of the tangential and really important things that come along with how do we protect data, how do we protect privacy, et cetera. And so this notion of data lakes, right, and understanding and accessing data, super important. And science and healthcare have been doing this for a long time, right? Data sets are at the foundation of everything that we do. So the digitization is something that has to happen. Securing this data while also making it accessible, super important. And so I think we need to address a few cybersecurity sort of housekeeping, zero trust, understanding who has access to data, ensuring that the right folks within the care plan have access to this data, and then ensuring that the federal government and this administration incentivizes the providers. You talked about rural health. There's some money set aside on helping those folks address their patient populations. So coming out with some thought leadership around this is how you secure the data. These are some AI models that you should be looking at to improve patient care, et cetera. I think all of that exists. We just need to, as a community and industry, do a better job of making those resources available and those best practices available. And so cybersecurity is something of utmost importance, which is really, something we have to do in tandem with delivery of AI. And then also the governance, right? If you don't have strong governance of access to data, where the data sits and is stored, it's going to be really interesting because you're going to have someone doing it a little bit differently. And that difference, even though it might be slight, is where bad actors and ransomware can sort of get in. And so updating the HIPAA regulations, understanding how providers will be incentivized to adopt cybersecurity, deploy AI, et cetera, will be something super relevant and super important as we go on this modernization journey.
Tim, it's great to have you here. Thanks very much for joining.
Thanks, Francis.
Molly Prieto of the Department of Health and Human Services and Justin Kerr of Google Public Sector. Welcome to both of you. Molly, I start with you. How are you approaching the next generation of standard setting for EHRs?
Well, standards happens to be one of my favorite topics, so it's a good place to start. First of all, thanks so much for having me. So standards-based certification and functionality has long been a stalwart of ONC, which is the Office of the National Coordinator within Health and Human Services. And standards-based has been the direction of making sure that systems can talk to each other and making sure that interoperability is here and now. I know one of the things that I always hear from my family members is, why do I have so many different portals? And why do I have to log into all of these different places to get information? That should be more easily accessible. And one of the ways that we can do that is by making sure that standards are the foundation of all of the systems that hospitals are using and providers are using and that we're using when we log in to access our own information. So standards-based is certainly the way to make sure that we can speak the same language to each other. As someone who is not bilingual, I really appreciate when systems are able to, do that translation for us and make sure that, if I'm being seen at a hospital and then at a new physician 2 weeks later, that physician could access that information. So standards is really the way to make sure that we're driving on the same road, speaking the same language.
What are the carrots and sticks that are available to an organization like ONC to drive compliance? Maybe is the wrong word, but cooperation among all of the various stakeholders here?
Absolutely. A very important question, right? It helps a lot if everyone is playing the same game. So one of the things that ONC has is the certification program. And our certification program, while voluntary, is reinforced by our friends over at CMS. And CMS has a few different programs that include payment incentives, programs like promoting interoperability, and they do incentivize the use of certified systems, and they also incentivize the use of certain standards. So by encouraging the use of certified systems and technology that is using standards-based functionality, we're able to really work nicely with CMS to be sure that the providers and hospitals are being incentivized for the use of functional tools.
Justin, welcome. It's great to have you here too. She talked about everyone playing by the same rules. What does that look like from an implementation or practitioner perspective?
Right. Yeah. And thanks for having us. You know, I think you brought up CMS and also how you partner from a ONC ASTP perspective. And one of the, in addition to standards and kind of the rulemaking that goes on, there's also voluntary programs. So CMS is a health tech ecosystem that recently launched. So Google, among other companies, signed on, Google overall, not just the part I'm in public sector, but to kill the clipboard, right? So how many times have we all gone to the doctor? You filled out the forms online, you filled out the forms last time, you show up again, you get handed a clipboard to put in yet, write down the same information again. So how do we get out of that even when some parts of the system don't have standards yet? And so why is it that I can put a concert ticket in my virtual wallet, but I can't put my health insurance card in many cases? So how do we create ecosystems that sit with and alongside standards, but that even are implemented voluntarily through kind of initiatives that provide a space to develop those shared ways of working and kind of ways of collaborating.
When you talk about creating an ecosystem, how much of that is technology infrastructure and how much of that is cultural in changing the way that organizations do business, process patients, all of those kinds of things?
Absolutely. And I'm lucky because I get to do the technology part. And I think that's usually, in a lot of ways, can be the easier part, right? But it's really a multiplier and an enabler. If we can figure out the technology and remove that barrier, then I think it can create the avenues for people to actually make it real, to have the cultural change and to have, see the value, right? Because no one's going to, continue to invest in developing new ways of working if it's not kind of delivering those outcomes that patients are really looking for.
Molly, Tim and I talked in the first part of this program about artificial intelligence. How are you seeing AI impact the way that people think about standards and implementation?
Absolutely. I don't think we'll be able to get away from AI anytime soon. And it is a tool with a huge amount of potential. So one of the things that, as the government, what we've been trying to find is the right balance between making sure that places like Google and all of the, private sector developers have space and room to be innovative, and while still making sure that patients and providers trust the systems that they're using. And so one of the ways that we think is a really good way to make sure that, providers trust the information that they're getting back from, AI is transparency. And so how can we, kind of make sure that everyone who is using the tool understands what the inputs are? I know Tim mentioned, making sure that the data is good. In a prior life, I also used to do implementations, and I always said garbage in means garbage out. So how can we be sure that that's high quality data and that when the tool is, using all of that information, that it is then giving answers that the provider trusts. So transparency is a great way to do that. We have some of those transparent features built into our certification program. So certified technology is being transparent about the way that they're, designing algorithms and making those answers available to the users. So I think that's one really important part. The other thing that the federal government can help do is incentivize use of new technologies. And so I know the department has been, really big in making sure that there are funding opportunities. I think in the last segment, you also talked about the Rural Health Fund, Transformation Fund that will be available soon. And so that's another really great way to encourage the use of, new cutting edge technology, perhaps in places in the country that haven't, had the same influx of funds in the past.
Yeah, the challenge I imagine in that area is a lot of those parts of the country are getting bandwidth where they've never had it before.
Certainly.
But the technology to leverage that bandwidth is not as readily readily available there as it should be, and they might be the parts of the country where they need it the most.
Absolutely. I grew up in a very rural area, 500-person town now, sadly, I think down to about 400. But I still don't have cell phone service when I visit my family members there, and they only recently got internet that wasn't dial-up. So certainly understand, the challenges there. The closest hospital to that area is 40 minutes away now. So making sure that as we're investing in those communities, that we're investing in the right things first. Certainly broadband is a good way to do that. And then making sure that the industry is able to provide tools that can work in a variety of ways, whether that means having downtime procedures or being creative about the way that they could download things offline.
Justin, how is the rural healthcare scene, landscape, being impacted by some of these kinds of issues that you're working on?
Sure, and I think maybe tying together some of those points about accessible technologies and bandwidth constraints and things like that. We had a great partnership with a partner called Drive Health in the state of Illinois, serving the use case for maternal and early childhood health. So in these underserved populations, how do you reach and have enough contact points for care during pregnancy, early postnatal? And so what Drive team has is a virtual nursing assistant that can do follow-ups and check-ins with those patients, and they supplemented that with Pixel phones and Fitbit devices. So all in the Google ecosystem, we're very lucky. So those kind of, now you have a wearable, you can actually take continuous readings, right, and monitor health. If the patient opts into that kind of a program, you're getting those readings without having to go to the doctor and check in on those things. You're getting that kind of out of the box. And then with a mobile device, you maybe can have care engagement, reminders, things that increase accessibility without, again, going, having the provider there, maybe not at all, or needing to go in person and do that, especially with, a newborn.
Two items that we talked about earlier in the program also come to mind as you're talking about these issues: privacy and cybersecurity. A lot of PII, a lot of personal information to protect and to make sure that is protected from all kinds of potential threats. What does that look like from the ONC perspective?
Sure, that's a great question. So within our certification program, also, we do have some components to ensure that certified systems are meeting privacy standards. Our friends at OCR, the Office of Civil Rights, who are responsible for much of HIPAA and making sure that folks are complying with those, are great partners. And so we've worked with them in the past to have a security risk assessment tool that hospitals and providers can use on their own, do some self-assessment, make sure that their systems are meeting their expectations and are meeting the certification criteria. So that's certainly one way. I think another component, you asked about standards to start. There are some newer standards that are up and coming. FHIR APIs, one of our favorite topics to talk about over at HHS. But there are new ways to do consent and more ways to ensure that the data that is being exchanged is privacy protected and privacy forward. So that's certainly using standards is another great way to ensure that all of our data is kept safe.
You've mentioned the certification process a couple of times. What does that entail, and what are you certifying to whom?
Sure. So the ONC certification process is a series of criteria that EHRs or other health information technology can demonstrate that they have met those foundational criteria. And we have partners that work with them to go through testing, and so they can test their systems, demonstrate that they're meeting these criteria, for example, the privacy criteria. And then once they have demonstrated that they meet all of these criteria, then they are considered a certified system. And then providers and hospitals can use those certified systems in programs like promoting interoperability that CMS runs to demonstrate that they're using technology in a meaningful way. So we can nerd out about certification all day, but it's a program that's been around for many years, and we recently updated it in the last two years or so.
What drives those updates? Is it incremental gains in technology? Is it gains in demands from patients or from the healthcare systems providers?
All of the above. So we hear a lot of feedback, from the developers, from patients, from clinicians about what challenges challenges they're facing and how we might be able to better address those. Another one, not to be a broken record, is standards-based. So as standards are updated and released, we want to make sure that the program is referencing those most recent standards. I think the last time we updated, we had some that were 10 years old. And so making sure that we're able to stay up to date and that the technology can reference the most recent ones. We don't want to be the reason why folks aren't able to innovate or move forward. So much of it is to make sure that the systems are rising to meet modern technology and most recent standards.
Justin, I noticed while she was talking about Fire API, you were particularly, you got really excited, jazzed about that.
Yep.
What about that concept struck you?
Yeah, so I think making those data accessible and also, again, across use cases. So certainly interoperability for patients having access to their own personal health records, being able to share them seamlessly across providers, but also to have enough both ability to work across the standardized data and the unstructured data powered by emerging AI capabilities to, for example, at the Uniformed Services University of Health Sciences, where our nation trains the medical personnel to care for military service members and their families. So we have a partnership with USU where they are developing models to help inform care. So, for example, their first model they deployed with this system was about wound closure. So a lot of different factors could go into what's the ideal time to close a wound to minimize the potential for complications. And they have a big amount of data that they can inform those decisions from past patients and their outcomes, but then bring that model into consideration with the patient that they have, in front of them. So how do we take that big pile of data and create meaningful models that can inform clinicians and say, okay, maybe in this case, with this patient's history, it's better to wait a little longer, to close earlier. In that case, that's just one example of how you can build, value out of once the standards are there, then the data become accessible, then you can scale, innovation in healthcare.
Are the data analytics tools to perform that kind of analytics similar to other types of analytics tools, or are they unique to that particular application?
Great question. So a lot of the foundational technology is shared. And one thing that, for example, FHIR standards give you is a way to reference those data in a repeatable way. So just like in other technology schemes, right? We need to kind of understand the data we're going to get in order to make meaning of it at scale without a lot of extra work. And that's what a lot of those standards set the foundation for. And then we can operate on them at scale more seamlessly, whether they be FHIR or, unstructured with, AI-enabled ways to look at those data.
Now I understand why you were so excited when you talked about that. What do you think, Justin, will continue to drive innovation from the technology company perspective like yours? What will incentivize you to want to keep driving forward on these kinds of things?
Sure. I mean, Google's a big place, but I love to work with HHS and the divisions within HHS, and we have long-standing work with NIH. So one of the things that gets me very excited is connecting healthcare and basic research. So now we're at in a new era where we have a great feedback loop from basic science into healthcare and really quick ways to bring the things we can learn from healthcare, back into basic science. So for example, at NIH, they had an initiative where they wanted to, at scale, provide medical images for research R&D applications, right? How do we make the next best model to look at images and detect cancer early or help clinicians? And to do that, you need properly de-identified, non-re-identifiable medical images, X-rays, CT scans, to create and train those models with. And so how do you do that? Well, humans can take away the MRIN and the patient name and things that shouldn't be available in that use case, but that's very laborious. So if we can get a machine to do that, to redact that information, then we can scale this much more quickly. So that's kind of the promise, where you can operate at these new scales by using tools powered by AI to kind of make the information available across those dimensionalities, where it needs to be identifiable for an individual patient, where it needs to be de-identified to power biomedical research.
We have about 30 seconds left, Molly. What will you be tracking moving forward in all of the areas that we've talked about? What's kind of over the horizon now that you expect if we got together a year from now, we'll be talking about?
Yeah. Well, Tim told an amazing story about his daughter playing doctor and having a computer in front of her. And I thought, oh my gosh, I want in a year for that computer to not be the center of the visit. I want it to be the patient again. But I think a good way to get there is making sure that we're encouraging innovation, using the most up-to-date standards, relying on our friends in industry to make sure that those tools are available and accessible, and helping use, federal government resources to be able to make sure that they are available everywhere, regardless of geography.
Molly, it's great to have you here. Justin, thanks very much for joining me.
Things off for us, Dr. Andra. Research areas in this particular field are really keyed in on electronic health records, EHR right now. What's state of the art? What are you keenly aware of or focused on?
When I think about this, the question of electronic health records, they're not just for record keeping at this point. They're part of a data system for health that can bring data from not only electronic health records, but other sources that can be used to create new kinds of information than we've had in the past. So, that electronic paper record, concept, we're over with that, and we're moving past that. And so when you think about getting data in new ways, using artificial intelligence to analyze immense amounts of data, we can start to think about doing research for different kinds of things, both operational research and then what you think of as clinical research. So, an example of operational research is, how do you free up clinicians to actually take care of patients instead of being the data entry people? So things like ambient listening, I'm sure most people have been in offices now that's even present today. And so it's a chance for AI to use voice recognition to record a encounter with a patient, accurately put all that information in, while the provider can actually engage with the patient, talking to you directly instead of what you often see is, leaning over and typing on the computer. And so that frees that up. That creates a better doctor-patient or nurse-patient relationship and allows that to move forward more quickly. You can also use AI with health records to help get the right patient to the right place at the right time to do that more efficiently. When I think about it, one of the things I like about being at MITRE is we don't operate just in health. We operate FFRDCs across the government spectrum. Well, we can actually take a look at what are we doing with air traffic control? What are we doing with ground transportation? What are we doing with military logistics? And take those understandings, that experience, those capabilities, and look at how could we use those to accelerate some of these things that we're doing in healthcare. And so, instead of having to reinvent the wheel on all these things for health, how do we modify wheels that we already have? And that's just on operational. And then on clinical, how do you take electronic records instead of doing traditional research with a registry and entering all the data on individual patients, then trying to analyze it? Could we start to pull data not only from electronic records, but combine it with other data from wearables? My guess is a lot of people have watches that are already streaming data on their vital signs. There's purpose-built wearables that people can use that will provide data. Combine that with data from pharmacies, other sources, and we can start to look at how do we design clinical trials in new ways instead of just the traditional randomized controlled trial, which is a very difficult time and expense way to do things. How can we create additional ways to get accurate information? And then how can we use that information to identify which patients can get which treatments or clinical trials more effectively and efficiently?
Our audience will note that one of the earlier speakers in this program, Tim Boltz, told a story about his daughter and how she plays doctor versus how he played doctor when he was a kid. He had a stethoscope and some of the other tools. He thought it was really funny that his daughter had a laptop while she was playing doctor. That was like amazing to me. And some of the benefits that you talk about there, really notable and evident when anybody is in their doctor's office these days. What kind of challenges, Dr. Andra, big picture, do IT leaders have to look at with the sort of advancements in technology, in layering in those different sources of data? What do they have to think about that they really didn't have to think about before?
I think it's how do you think about what the end user of this technology needs to do their job more effectively? How does it help a patient understand what's going on? How does it help a patient access the system more effectively? The first iteration of electronic health records did a lot of really good things. It provided information more seamlessly. But what it also did was made providers, the data entry people, caused a lot of burnout, still does. You still hear doctors, including the one that I'm married to, talk about having the frustrations of having to do data entry and looking at records. How do we free them up from that? Use technology now to get to the next level, to where we're using it to free up providers rather than lash them to their laptop, and so that your daughter, hopefully it won't be your granddaughter, right? Your daughter will be able to put away that laptop for the most part and be talking to a patient, examining a patient, interacting instead of entering data in those requirements. And I think we're on the verge of that, and that's a place that AI will truly help us create a better health system, one that really is higher quality, provide information back to the provider and the patient rather than them providing information into it.
Michael, I want to get back to artificial intelligence that he teases out there in a moment, but before we get there, data sources, you're on like the pointy end of the spear relative to those issues, particularly for the work that you're doing with veterans. Talk a bit about societal community data, how you layer those in to better help patients, better help the care experience.
Yeah, actually, helping veterans transition is the sole reason why Unitas was created back in 2013. In fact, both of our founders are military veterans. Dan Brillman, current Medicaid director under Dr. Oz, and Taylor Justice, CEO, because they experienced firsthand the challenges that veterans were having transitioning into civilian life. And if you think about it, if you put yourself in their shoes, when a soldier's on base, they have all the resources readily available for them, things like childcare and healthcare. But the moment they transition, they're inundated with over 60,000 veteran service organizations. And the onus is on them to figure out how to navigate that. So Unitas was created to simplify that process by providing the infrastructure that allows organizations to collaborate around a veteran's journey. And so since we know that 80% of our personal health outcomes are determined by things like health-related social needs, providing better infrastructure and delivery capabilities leads to proven clinical outcomes.
Talk about responsible use of that artificial intelligence that you mentioned, Dr. Andra, particularly in these federal health systems. Like, that's a bit of, or can be, a loaded term today. What does responsible use of AI mean in the healthcare field?
Well, the first question we always ask ourselves as we're looking at any AI tool, and every AI tool needs to be assessed individually, both when it's brought to the market, but then throughout its life cycle. Because one of the things that's different about an AI tool from a traditional medical device is, when you get a traditional medical device approved, it's pretty much going to be the same, and when you've changed it. The thing about AI is it's continuing to evolve as it's getting new data in. And so is that AI tool that you originally approved still operating in the same way? And so we're going to have to think about how we assess these over a life cycle and not just at initial approval. And so the big question is always, how much can you trust the information coming from it when it's working appropriately? And number two, how do you know it's working appropriately?
Life cycle is a really important word, in my opinion, for what he drew out there. Getting back to veterans, to the life cycle of their care throughout their work with the federal government, with the U.S. military. Are there different phases of that life cycle where they need to think about different things relative to their data? Michael, does it change over time?
Well, yeah, I mean, I think a veteran's journey never ends, whether whether they're in uniform or they're transitioning into civilian life. So it's important for us to remove the barriers and silos as they look to get connected to care, provide more resources within their community. So data plays a huge part in that, just allowing healthcare providers that care for veterans, community organizations that care for veterans to proactively reach out and engage them for health interventions to lead to better outcomes before those needs go unmet and they become emergent and more costly downstream.
Research relative to cybersecurity, which has been a really common theme throughout this program. Where are the needs right now, Dr. Andra? Like, what do we need to study in order to do the protection of PII better in the future as these tools advance, as, to your point, artificial intelligence starts to layer on there? What do we need to know now in order to do that better later?
Yeah, when I think about cybersecurity, there's some well-known approaches that we can continue to evolve and adapt into healthcare. Zero trust architectures are a common one. It's well known, and we see it in many places. And that is, you don't trust any device, individual, or source until it's proven to be trustworthy. And so, how do we adopt that? Another thing is we look at research and using AI to provide any kind of information into the health system is how do you access that data and what's the governance around that? Who can access it, for what purpose, when, and for how long? And then we look at how do we bring that data together? Do we do it in one big bundle, aggregate everything in a single source? Or do we use a more federated approach where the data lives where it lives? You access it to get the information you need, and then only that information is taken on, not the data itself. All those approaches can help protect data and individuals. The other thing, though, in an AI world that we're so interested in is that's transforming so much of healthcare and society is what are the unique risks in an AI world? And so one of the things we talked about tools, when you traditionally think about cyber attacks, you think about somebody either locking up a system or pulling information out of the system. In an AI world, where the tools themselves are evolving as they get new information, what's the risk of somebody inserting bad information that will corrupt the AI tool itself? So not taking anything out, not locking it up, but just feeding it bad data. So that's something that we take a look at and can leverage what we do from across the federal space, everything from national security to the public sector. And then the other thing is, how do you prevent a cyber attack from becoming a cascading problem through the health system? And we've seen that a couple of times. The Change Health was a company that had a cyber attack, and it caused billing and reimbursement processing problems throughout the health system. It cascaded, and the federal government had to step in, CMS, to really stabilize things until that got resolved. You saw an Amazon Web Services shut down that impacted and cascaded across the health system. So understanding how do we identify cyber attacks early enough to prevent them from cascading or interrupt the cascade once it's started.
I'd love for you to weigh in there too, Michael. You've been a champion for better or more effective data sharing standards for a long time. What role does that play in this discussion?
Yeah, and I actually think that's the biggest challenge that we see in industry today. And in order to improve trust and drive improvements around things such as homelessness, suicide prevention, and clinical outcomes, key partners of the federal government need to be able to balance both data sharing and privacy in the hand-in-glove relationship. For example, today, the VA could share information around their veteran populations to state VA agencies, but that's become extremely challenging. And the reality is, at the end of the day, the state VA offices have to endure additional workloads just so they can better understand their populations.
I'd really like to focus the remainder of our conversation on rural healthcare. Maybe I'll start with you, Dr. Andra, and just say, what are the opportunities out there in the rural healthcare space right now?
Well, for rural health, there's a couple of problems. Just the obvious one, distance. And so there's all this promise around telehealth, but telehealth is only as good as your upload-download speed. And so when you take a look at rural health, healthcare doesn't exist in isolation. It's part of society. It's what you've talked about. It's part of a larger community. And so how do we look at rural health in a more holistic sense? How do we look at it from the FCC point of view, the healthcare point of view? How do you provide the rural population with the tools that they can actually use in the environment that they're in? Separate of all that are some of the stresses in the rural environment in terms of the mix of reimbursement and the stress that rural hospitals are under.
Can data and analytics better perform or better enhance those efforts, Michael?
Yeah, absolutely. And first, when it comes to rural health policy and the rural health transformation, I just want to give praise to the administration for improving funding. $50 billion is a major commitment. CMS is spearheading the rural health transformation, and there's a sense of urgency behind the program. And as we know, rural health is under immense financial pressures. Just over the past decade alone, more than 100 rural hospitals have shuttered their doors. So for us, right, this is a welcome opportunity to really drive better outcomes for the rural populations. And we really see two primary opportunities. First is around the data itself, being able to proactively predict and identify those that are in need so that they can be enrolled into programs. And we do this through what is known as a self-sufficiency score. So a self-sufficiency score is taking public data like census data, private data like consumer data, but then leveraging our platform. And so we have algorithms based on our 85 million historical connections to care that drives our data to be able to precisely identify those that most at risk within a population. So I think for both the states, they can use that as a planning mechanism as far as benchmarking where their population is today. CMS can also use that as a benchmarking solution too, to see the progress that states are making with this investment. And then I think the second opportunity is really all around providing the infrastructure so that state and local agencies, payers, healthcare providers, and community organizations all have the ability to communicate, collaborate, and coordinate whole person care.
Ram Sriram of NIST and Egan Rinderer of Ninja One. Gentlemen, welcome. Thanks for joining me today. Ram, I start with you. How have EHRs evolved over time to get where we are today, and how do you expect to see them continue to evolve over time?
And thank you very much, Francis, for giving the opportunity here. EHRs actually evolved through several cycles. Initially, when they started, people were really using it for payment processing and scheduling and those kinds of things. And now they have evolved to be more reactive. And what has happened also in terms of their programming also, initially they were all put together bits and pieces. And later on, people have used some more modular techniques to build robust EHRs. Now what's happening in EHRs nowadays is that with the advent of artificial intelligence, the EHR vendors are trying to incorporate these technologies into this. So what's happening with EHR is that the EHR is not just a repository for the doctor to put history and physical and all the data that the doctor collects in the office or the hospital collects, but rather it's going to be an active system rather than a passive system in the future. And there's other thing that is going to happen in the future. Like for example, I wear a Apple Watch, and this is constantly monitoring me. Similarly, all this all these devices are going to monitor us all throughout the day. With the food we eat, you're walking, that's being monitored. Your physiological state is being monitored, everything. And all of them are going to go into something called you can call it an health persona of individuals. Now, that's one part of it. Then you have the electronic health records, which are going to incorporate all the lab data, imaging data. In addition to that, your genomic data also. Because what happens is that there are certain patients, they have some gene variations, and you cannot give them, for example, warfarin if they come with a stroke, okay, because they have a certain variation. And that information, if it's there in the EHR, you don't need to, you know what happens on that thing. So then you attach this EHR to your health persona, you get what is known as a personal health record. So in the future, that will be the main thing, the personal health record. And also, we will evolve from a doctor-centric or hospital-centric view to a patient-centric view. So the EHRs and the PHRs will evolve into a patient-centric view. And not only that, they will be active and intelligent. That's a very brief description, but we can go into details.
And I want to do that because you have a lot of experience in some of the areas where these technologies are breaking now. Egan, welcome. Thanks for joining us today. What do you see? You also have a lot of experience in this area from a lot of different perspectives. What do you see as the most important developments that people on the federal side should be paying attention to as these things develop?
Yeah, I will say, I think I don't think there's a tremendous discrepancy between the federal and the private sector when it comes to patient care. I tend to be very hard on vendors, and I am a vendor. I take that, I'm very passionate about scrutinizing my work and the work that we do as a company. But I go all the way back to the early 90s. The first startup I was involved in was an electronic payments disbursement. We helped physicians bill electronically, and that was novel at the time. And I left that and founded a company in the late 90s. We're talking 7-8 years before the first iPhone came out, that provided EHR access to physicians via tablets over, at the time, cellular data packet radio modem. So like the things that they used in utility vehicles, right? This was, at a time when Windows 3.1 was, Windows 98, or sorry, Windows ME had just come out. Like this was very, very arcane technology back at the time. But what was interesting about it is that it provided, the draw that physicians had toward it was that it was a catalyst, right? It helped them provide better care to the patient without getting in the way. And then as time progressed and there was more, HIPAA became a thing and people sort of started smelling the opportunity to cash in on bringing IT to bear in healthcare, things changed dramatically. And it became more about how hospitals could collect the data they wanted, as opposed to how can we provide better patient care. And what's also interesting at the time is my sister was graduating from med school, going into practice, private practice, and I watched this evolution through a physician's eyes. And I saw the frustration because what was happening is she was spending more time with the IT systems that she was given to purportedly improve patient care than she was with the patient. Right. And we saw that trend continue. And now the industry has sort of shifted back to this idea that, we need to become more patient-centric. And I think that technology has reached a point. There was this interesting aligning of the stars in the late 90s that allowed some really novel things to be done around automation of patient care and improving patient care through technology. We're sort of at one of those inflection points again now, where the pragmatic use of AI, right? Not the blanket use, not throwing a sticker on a thing and saying we're going to leverage AI now, but the actual pragmatic use of AI, like Tim alluded to, right? Note-taking is a huge burden. In fact, my oncologist, who's a phenomenal doctor, has a person whose job it is to take the notes while he sees me so that he isn't distracted by banging on a keyboard. It shouldn't have to be that way, right? Technology has reached the point where it doesn't have to be that way.
And carrying that, actually, you made a very important point. Tim also talked about this automated note-taking thing. So I think one of the things that's going to the future office of the doctor will be You have these videos, audio, everything. So you're just talking, you and I are talking, the doctor and the patient are talking. And there's also other kinds of irrelevant questions that are being asked and things like that, like how's your family and so on. You don't want that to go into EHRs. And these things will be smart enough to take out all those things and only put the appropriate information that is required in EHRs. And hospitals are doing, and there are offices which are experimenting with that right now, and they're using that. And that's pretty neat because the doctor doesn't need to go and type on the system all the time. Instead of that, your main goal is to do a patient-doctor interaction, and everything is automatically done. And another thing that is going to happen is that a lot of times when the patient goes to the doctor, there are certain emotions which has to be captured. Like you'll say, oh, I have a stomach ache, but you really don't have a stomach ache. But if you can capture that facial recognition kind of things, and the system captures the emotions and tells the doctor actually, or the automated system, that really the person is not really sick, but is feigning to be sick kind of things. So these are the kinds of things that you're going to see in the future. Of course, previous speakers have talked about privacy and so on, and that's going to be an important aspect of how do you manage privacy, security, and those aspects of it. And there's something, we came up with something called P9 medicine, where medicine is participatory, preventive, predictive, and so on, and there were 9 P's involved in there, and privacy and protectiveness, and also it has to be appropriately priced. That's very important because medicine, as you know, is very expensive, and the idea is to reach the medicine for all at a reasonable price.
Mm-hmm. What do we need to do as a country, or what does the federal government need to do to get from where we are today to the vision that you just described?
There are lots of agencies in federal government who have specific tasks of doing these things, but my agency, NIST, is more in terms of helping this whole process. Like we are actually in the Constitution, if you know that Article 1, Section 8 talks about weights and measures. Okay, so we really are in the process of making sure that these systems work perfectly. So in terms of trustworthiness of the systems, benchmarking, and I guess Molly talked about the certification process, and we develop a lot of tools to help in the certification process. So we develop the testing tools. So right now we have been testing tools to develop the standards that have already been developed by, are supported by ONC and so on. But in the future, we also have to have these tools which are actually use AI techniques to automatically generate the interoperability between various systems. So we are mostly in the R&D kind of area, but in terms of the incentives the federal government provides, and there are other organizations like ARPA-H or HHS and those organizations which are putting in actually considerable amount of funding to make this happen.
Mm-hmm. Ram talked about testing and the importance of that. What does that look like from the vendor perspective, and what does that look like from the provider perspective, who maybe doesn't want to be involved in being a guinea pig in the
and I don't think there's any maybe about it. I think the vast majority of providers are looking for ways to be able to hit the patient numbers that they're loaded down with and provide good care. That's what they care about. From their perspective, the patient isn't data, it's a human, and that's the way it should be. From the vendor's perspective, I think the number one thing that I see that's sort of this battle of wills between whether it's NIST or the federal government writ large and the vendors is the vendors are very protective of their intellectual property. And when it comes to AI, your intellectual property protection means I don't like transparency. When it comes to healthcare and AI, you need absolute full transparency. There is no other way to do it responsibly. And I'm very happy that I'm not on the regulatory side of that fight. As a vendor, we have a very open approach to that. Our AI that we use inside of our product is extremely pragmatic, extremely simple to understand how it's being used. There are no privacy issues with the way that we're using it today. But I think we have to come to terms between the will to make a dollar and the will to protect people's privacy, security, and health. And if that's not understood, which side of that argument should win outright, then there's probably a different discussion.
That's right.
Yeah.
What does that conversation continue to look like as technology evolves in some of the ways that Ram described and you talked about earlier? Strikes me, and privacy and cybersecurity have been themes of this conversation on this entire program so far, and I imagine they're two of the things that you think about all the time.
They are, and here's the struggle, is the people who have the most vested interest in protecting that are the least equipped to discuss it, and that's a problem. That's why we have regulatory organizations within the federal government. That's why we have chosen as a people of a democratic society to establish organizations like that. When experts talk, we need to pay attention. But that goes both ways. It cuts both ways. So when the technology experts talk and they say, look, here's how you properly secure this, here's how you employ proper transparency and traceability of the data and all of the things, we need to be listening to the patient care professionals as well and say, that's all great, but this comes first. The patient's well-being comes first above and beyond all of that. So sometimes those two things can be in conflict with one another in terms of the speed at which we can move and progress technology into medicine. I think that natural friction is okay, and it should probably be maintained over time. So it does slow things down a little bit, but that's an acceptable rate of progress, I think.
And Egan also mentioned, continuing on that, about AI incorporated in their system, but we also need to have certain tools and techniques to measure this thing.
Yeah.
So metrics are very important. Like when people are talking about large language models, you get output from them. So how do you measure the trustworthiness? How do you measure whether this is right? What are the metrics in there? And these are some of the things that we are interested in.
You frame that as kind of a rhetorical question, so I'll ask it as an actual question. How does one measure trust in something? How does one measure the outcomes, the outputs that you're getting for accuracy and so on?
Yeah, that's a pretty good question. Take a long time to answer that in any case. But there, even in trust, there are several aspects of it. So you got to, first of all, clearly identify what are the various aspects of it. And then you need to show that how we are going to measure this particular thing. So trust is only one part of it as such. And the other is reliability of the systems, uncertainty quantification of the systems are very, very important. So the number of dimensions of these things that you have to look into. And, it's a research area that we are pursuing, and so something of interest to us.
It's really, we could do a whole show on artificial intelligence in this space. This is an issue, though, that you've been involved with, I read, for 30 years or longer. I think a lot of folks think artificial intelligence is relatively new.
Actually, I started working in AI about 1982, so it's been almost 4 decades. And I've seen several waves of this AI. And in the 80s, it was mostly knowledge-based systems or symbolics. Then in the 2000s, you have seen the evolution of neural networks, and they call it deep learning. And then deep learning has itself certain flaws because they're very good at pattern recognition, but sometimes they tend to they don't know the reasoning. So, and then people are now combining these knowledge-based systems of the 1980s along with the neural networks, and we are seeing the evolution of neurosymbolic computing. And this neurosymbolic computing is going to play a major role in the future of AI in medicine.
What will drive that, and what will the result be in your view?
What will drive it is because what has happened is that in terms of the deep learning, as you have seen some arguments even by Turing Award winners and the Nobel Prize winners on this, is that these systems have come to a stage where they've come to a deep end kind of thing. Okay, so and they're also, like, for example, the LLMs. There's something called hallucination, but also it's a different word people use for that. They can make up some things. So if something makes up something, then these knowledge systems will have to come back and say, no, it's made up. It's a context. Now, in other words, if a child goes to the hospital and they say you got lung cancer or something like that, and the knowledge system will come and say, no, this particular kid could not potentially have that thing, and there are other things that we need to look into. So it's a combination of this neural network, which is doing this, which is what is a system one kind of thing, which is doing this processing, and this another system, which is a slow system, which is system 2, which has to make sure that is actually working properly. So you have to have both the system 1 and system 2 to make it a robust system of the future.
There is so much more I would like to cover with both of you, but we're out of time. Ram, Egan, thank you very much for joining me. It's great to have you here.